Sorry, we're running a little bit over time, but if you have questions, Christian will be around to ask, and for those people on Zoom, we might write with his answers to questions. So we have, thank you, Christian. So we have one more talk. So we have one more talk before we have a lunch break. Sorry, things are running a little bit over time, but we'll try and catch up. So I'd like to invite Dr. Kristina Horne. She is also a postdoctoral research associate here at the University of Sydney, and she works alongside Professor Murren Irish, who is part of our group as well. And Kristina's research interests are in neuropsychological function and healthy aging. And today she's going to tell us about apathy and anhedonia in FTD. So I'll just set up the slides. Yeah.
Is it best if I just hold it?
Yes, and just stay.
Just stand here.
Right,
yeah.
here we go.
Yep. Okay. Hello, everyone. Thank you so much for having me here to present today. It's such a pleasure and an honor to be here. And as Morel mentioned, I'm going to be talking to you today about apathy and anhedonia in frontotemporal dementia, two symptoms that we've been doing quite a lot of research on in my lab. So I'm in the Mind Lab with Professor Murren Irish, and also within the Frontier group more broadly. And I guess one of my aims out of this talk is I really want to sort of increase understanding and awareness of what apathy and anhedonia might look like in those who have frontotemporal dementia, so how to know if one of your loved ones might be experiencing this, and just to provide some simple tips that might be useful in managing some of these symptoms and supporting these people. And I also, you know, as carers, you guys are kind of the experts on this as well. So I would be really interested at the end to hear your thoughts and feedback on your experiences with these types of symptoms and the things that you found to be helpful. So, do I just go? There we go. I'll skip past this slide because everyone has done a lovely job of explaining frontotemporal dementia. But when I'm talking about apathy and anhedonia, essentially they can be broadly categorized as motivational disturbances in frontotemporal dementia. So apathy is a real loss of motivation or drive. So it's this real kind of spark of energy that drives us to do things and to engage in activities and behaviors. Whereas anhedonia is the diminished ability to experience pleasure. So these two symptoms, while they kind of sound and can look quite similar in the patients, they're actually distinct. While they do overlap, so there's a lot of the time people might have a bit of both. It's also possible for someone to have apathy without anhedonia and vice versa. And when we're thinking about apathy, as many of you would probably know, it's one of the initial features of the behavioural variant of frontotemporal dementia. But we're also now starting to understand that it's prevalent across all of the frontotemporal dementia phenotypes. And it is one of the most common and disabling non-cognitive symptoms of dementia, and really significantly increases carer burden. So that's this strain and stress that we're talking about and that you experience as carers. And for someone with apathy, you might notice that they don't want to participate in activities and conversations as much. There might be some sort of blunting or flatness in their emotional expressions. They might be a bit less concerned about their own or other people's behaviour. They might be a bit socially withdrawn. And this can actually co-occur with disinhibition or impulsivity. So the things that people are saying could at times be a little bit inappropriate or offensive. And other signs is that they might have no motivation to do really routine or basic tasks like brushing their teeth, having a shower. These things can all become a little bit overwhelming for them. They might rely on other people to suggest and to organise activities. So one thing that we find in apathy is that the issue is often around thinking of what needs to be done and that initial being able to initiate that activity or task. But sometimes if you give that external prompting of telling people what they need to do or organizing it for them, then you can get, they're much more likely to carry through with a task or activity. They might be less interested in joining in on conversations or talking to new people, and seem unemotional in response to news or, quite serious personal events. They might seem a little bit uninterested or detached. So these are all some of the hallmark features of apathy and the signs that you might notice in someone with frontotemporal dementia experiencing it. And some recent work by Stephanie Wong in Fiona Comfort's lab was looking at apathy in participants with primary progressive aphasia, where we just heard about that from Dr. Layton. And so as you would know, this is typically classed as a language disorder. This is the thing that we sort of know it for. But this study actually showed that all of the participants with primary progressive aphasia had greater apathy scores than healthy controls. So if you're looking on here, you can see there's each of the different types of primary progressive aphasia that were assessed. So left and right semantic dementias, it's just two different presentations of the semantic dementia, progressive non-fluent aphasia, and the longopenic aphasia group as well. So there was significant apathy symptoms in about 33 to 56% of people with primary progressive aphasia. So clearly this is not just something that's affecting the behavioural variant, it's something that's happening across all of the frontotemporal dementia syndromes. And the carers were completing a questionnaire in this study as well about carer burden, and regardless of what type of FTD the patient had, the carers were reporting really high levels of carer burden. And apathy was actually a significant predictor of this, even after accounting for the patient's diagnosis, the disease duration, and cognitive and language impairment. And so this, I guess, to summarize, apathy is really prevalent across the primary progressive aphasias, which are typically characterized as language disorders. Regardless of the type, the carers had significant levels of burden. So this really highlights the need for us to routinely assess apathy in primary progressive aphasias and to give education to caregivers, because as a caregiver, if you've been told that your loved one has a language disorder and those are the things that you're expecting as part of the disease course, and then suddenly showing these signs of apathy, then that can be quite confusing and upsetting if you're not understanding what's going on. But when we're thinking about apathy, it's also really important to consider the influence of motivation and reward, because one of the main drivers of human behavior is the drive to experience pleasure. So we want to have good feelings. So primary rewards that we often seek out are things like food and sex, but secondary rewards are things like music, art, and money. So these are all things that give us some sort of pleasure or joy, and they stimulate areas that we call hedonic hotspots in the brain. So you can imagine with someone with apathy, one reason that they might be less motivated to do certain activities is because those things aren't bringing them enjoyment or pleasure anymore. And anhedonia is really this diminished ability to experience pleasure in response to things that previously would have been rewarding or enjoying. And anhedonia has been really widely documented in depression, so it's one of the key symptoms of depression, as well as bipolar disorder and schizophrenia, but is now recognised as a core symptom of frontotemporal dementia as well. It really predicts the level of functional impairment in behavioural varied frontotemporal dementia patients. And as I touched on before, it's overlapping but distinguishable from apathy and depression. So just because someone has anhedonia, they're not necessarily depressed, which is important to know. So anhedonia, while it looks similar to apathy and they can occur together, it really is a loss of interest in hobbies and pursuits that they previously enjoyed. They might withdraw socially, disengage from their regular activities. There might also be some changes in their intimacy behaviours with their partners and changes in their sexual behaviour. There might be a new insensitivity to loss, which has implications for things like their spending behaviour. But you might also see some new stereotypies or rituals, which is sort of like where they want to do certain behaviours in a particular way every time or in a certain order. And this is something that's new for the person. They didn't do this previously. And all of these changes with apathy and anhedonia, we really attribute back to the brain's reward circuitry. So this is something that we call the dopaminergic system, and it's really just a series of brain regions that are all connected and modulate our ability to experience pleasure, as well as our drive to seek out things that bring us enjoyment or reward. And while I won't go into all of the details of these brain regions, essentially many of them are affected from very early on in the frontotemporal dementia disease course. So it makes sense that we're seeing apathy and anhedonia in these patients. And one of the PhD students in the Mind Lab, Siobhan Shaw, recently did a study looking at the prevalence of anhedonia in frontotemporal dementia. And so you can see that she recruited participants with a number of the different variants of FTD, so behavioural variant, semantic dementia, and progressive non-fluent aphasia. And then she compared them to patients with Alzheimer's disease and some healthy older controls. And basically the patient's carers completed questionnaires looking at anhedonia, apathy, and depression. And then Siobhan did some neuroimaging. So the patients did a structural MRI scan. And then we used a technique called voxel-based morphometry, which is a fancy way of saying we're looking at the link between brain integrity and these symptoms. So looking at just the prevalence of anhedonia in these patients, you can see here the different patient groups. We've got the behavioural variants in red, the semantic dementia yellow, progressive non-fluent aphasia, Alzheimer's disease, and the controls. And we've got the ratings on the y-axis on our anhedonia scale. And essentially lower scores, let's just skip. Essentially lower scores mean more anhedonia, so less ability to experience pleasure. So you can see there that there's lower levels of, there's more anhedonia or less ability to experience pleasure in the behavioural variant and semantic dementia patients, whereas there was no difference from controls with the progressive non-fluent aphasia and Alzheimer's disease patients. So it was really, anhedonia seemed to be a feature of the behavioural variant and semantic dementia patients within this group. But also something to consider with this is what the person's personality was like prior to the disease onset. So is it the case that they've always been someone who doesn't experience as much pleasure in certain activities as other people? So Siobhan was measuring carers' ratings of the person's anhedonia before the illness onset and at the time of the study. And so you can see here within the red and the yellow, there's sort of a significant deviation in scores there. So there's a real decrease in the patient's ability to experience pleasure at the time of the study compared to prior to the disease. I don't know why it's skipping. Also in the Alzheimer's disease, we actually saw a significant difference there as well. But if you recall from the previous slide, their scores weren't significantly different from healthy controls. But still a little bit of an increase in anhedonia with the disease. Whereas we're not seeing any significant difference in the progressive non-fluent aphasia patients. So really this tells us that anhedonia is not just explained by someone's personality prior to the disease. This is actually a feature of the disease progression. And finally, when Siobhan looked at the neural correlates using the voxel-based morphometry, the regions that are coming up in the sort of yellow and red are the ones that were correlated with measures of anhedonia, apathy, and depression. So you can see with the anhedonia, there's sort of a few different regions that we're seeing there. Up the top left, we've got sort of some orbitofrontal regions there and a little bit of the anterior cingulate, which are all part of that reward circuit that I spoke about. And then we've also got some insular and striatal involvement as well for anhedonia. Whereas, so that means that when we're getting atrophy or degeneration in these regions, we're more likely to see symptoms of anhedonia. Whereas for apathy, we're seeing a little bit of overlap up the top in the orbitofrontal regions, but mostly for the rest of it, it's fairly different. We're seeing a different pattern of results here. And then similarly with depression, we're seeing almost no overlap there. So this shows us that anhedonia is distinct from apathy and depression at the neural level. And really, I guess, hones in that, that this is something that's happening in the person's brain that is causing these symptoms. And that's one of the key points I wanted to sort of hone in on with this talk, is that when someone has apathy or anhedonia, this isn't laziness. So if someone is, sort of sitting around and they're not engaging in their previous activities and they're not helping out with housework or wanting to talk to anyone, yes, that can look a lot like laziness, and that can be hard for sort of carers or other family members or friends to understand. But this is actually something that's happening at the neural level in the person's brain. It's not a choice that they're making. It's actually just difficult for them to either initiate things or think of things to do, or for them, they just don't get the same enjoyment out of those things as they did previously. So I think that's a really important thing to remember when we're seeing these symptoms in people with frontotemporal dementia. So I wanted to, while it's a complex issue, I wanted to give some sort of simple tips that can help to support someone with apathy or anhedonia. So one thing you may want to do is help them to establish a bit of a daily routine, because it is hard for them to think of what to do and initiate those things. Whereas if they've got a routine of this is what you do every day, and have some sort of visual supports to help with that, that can be really useful. And breaking down each of the tasks into simple steps. So rather than saying, come on, let's get ready for the day, it's go have your shower, then brush your teeth, then put the kettle on. These really simple one-step instructions, and then giving those prompts to start and to keep going with tasks, because as I've said, often people with apathy might struggle to get that initiation. But if there is some kind of external prompt from someone else, then that can really help to get over that barrier. Similarly, they might also be able to get started on a task, but then they'll sort of peter out or run out of steam. So giving them the prompts to kind of keep going can be helpful too. Using a checklist to really get that sense of purpose and satisfaction, even if they're just really simple tasks, like to put some washing in the machine. And electronic reminders and alarms can be helpful too, because you can't always be there to be prompting and reminding the person. So having, most people have some sort of digital device, like a smartphone, or even base, non-smartphones. You can set alarms and reminders and things. And that can give that external support to drive behavior. And another option is to give, if you're wanting the person to join in some activities with you, giving options for that rather than yes or no questions. So if you were to ask someone with FTD if they'd like to go for a walk with you, it's very easy just to say no. But if you were to say, would you like to come for a walk at the beach or at the park, then they kind of have to choose one or the other, and it's also giving them some ownership in that decision too. And try and work with them to identify activities that do still generate enjoyment and bring them to the person, even if it's something new. So sometimes people might develop a new interest in, say, music or in a particular type of food, which is part of the apathy and anhedonia symptoms, but that's okay. Embrace that. If there's something that they're really interested in now, bring that to them and let them experience that, because it brings them some enjoyment and quality of life. And as Gina touched on so beautifully earlier, your own self-care is so important. So if you're feeling that, you know, this is overwhelming, and given that what we know about the impact of apathy and anhedonia on carer burden, it's so important to reach out for that support when you need it. Family, friends, your FTD support groups, even what Gina did, going and organising some respite, all of these kinds of things can be really helpful for you to manage these things. So I'd just like to finish up by acknowledging all of the patients and families and healthy control participants that have contributed to this work, and the Mind Lab that I'm a part of, and the Frontier Research Groups, the Brain and Mind Centre. And as I mentioned before, we're really keen for your feedback and insights, because you guys are the ones that have actually experienced this. So if there's things that, you know, if you have insights on your experience of apathy and anhedonia in the people that you're caring for, but also if there's things that you'd like some more support with, or the things that you found to be helpful, then we're really keen to hear that, to sort of guide our future research and support tools. Thank you.